Welcome, everyone. Thank you for joining Amethyst at Penn's workshop today. We're proud to offer this content through the Amethyst at Penn Hub, which stands for Achieving Maternal Empowerment and Transforming Health Through Implementation Science and Training. Funding for this hub comes from the NIH's Improve initiative, which aims to reduce maternal mortality and improve pregnancy, perinatal, and postpartum care. We will be internally recording this discussion and we'll make some segments available on our YouTube channel for review after the session. Please feel free to put any questions in the chat. We will also have time for additional questions and almost like a mini office hours at the end of our session. So please feel free to pop them in throughout. This month, we're very fortunate to have Dr. Matt Kearney here from the Penn Mixed Methods Research Lab to speak with you about rapid qualitative analysis in maternal health research. Dr. Kearney is an assistant professor in the Department of Family Medicine and Community Health and the associate director of the Mixed Methods Research Lab here at Penn. So thank you so much for joining us today, and I will turn it over to our host.
Thank you so much, Casey, and thank you to everyone at Amethyst who's part of that and who's involved with this type of work. It's my distinct honor to present this talk to you today titled Rapid Qualitative Analysis in Maternal Health Research. My name is Matt Kearney. As Casey said, I'm an assistant professor in family medicine and community health, and I also have the honor of working with the Mixed Methods Research Lab, which is a service center within the School of Medicine that helps to basically do anything from soup to nuts for qualitative and mixed methods projects. So from study design, developing instruments, to analyzing, writing it up, we really have quite a range of potential offerings that we do there. And it's through a lot of that work that I have become deeply involved with some of the projects I'm going to be discussing today that are fantastic representations of applied rapid qualitative analysis. And I'll qualify this to say that this is definitely something that is I'll present through my work that I have in maternal and child health work, but it also has applications to other topics. And so I'll share some of those as well. And then, as Casey said, there'll be some time afterwards. So if you have any questions or anything like that, I've gotten a few in advance that I'll be tying in as well. But happy to stay as long as we need to answer this. And if there is anything, Casey, that comes up that's kind of like, stop the slides, let me know, and I'll certainly do that. I think that I've got about 50 slides, and I should be able to finish within the allotted time for that. So just a quick agenda for what we're going to go over today. So go into a little bit of an introduction about rapid qualitative analysis, and then I have 3 different cases that I'd like to present. I think each is a somewhat different representation of some of the ways that you could apply our rapid qualitative methods, and then leave time for any questions and answers that I can provide. So some objectives for the overall workshop. I think it's probably the front of everyone's mind is thinking, well, how is this different than traditional qualitative work? So I'd like to go through and to give a real distinguishing between rapid versus more traditional approaches. And then for rapid approaches in particular, I'm going to present, as I said, 3 different studies that each go through a little bit different process to achieve their goals, both in terms of rapid and traditional analysis. And then want to think about, with your own work, how exactly you could apply this and when it would be appropriate, and if there's any potential ways that we can help to support that today. So rapid qualitative analysis, or rapid qualitative inquiry, which is somewhat similar, but there are some distinctions between them. Refers to a family of qualitative methods that's designed to primarily generate actionable insights within a shorter time frame than we might typically have with a project. So the range can be anywhere from days to months, although probably not much longer than a few months with that. And one of the advantages of rapid qualitative analysis is that it balances the rigor that you get with traditional methods with the timeliness that you might get, so that you can provide that important feedback in real time with that. And I should just say that rapid qualitative analysis versus rapid qualitative inquiry is more of a larger strategy in which when you're conducting field work, you use multiple different data sources to try and triangulate findings very rapidly. And so I actually do have a study that's a nice example of rapid qualitative analysis with inquiry as well with that. some of the key characteristics for rapid qualitative analysis, or RQA as I'll refer to it, is that it is time bound, that there is a defined point at which you need to have results or findings by. You typically will have a defined structure, which is that you'll have an analytic tool already developed that you'll basically be filling in as you go through your data collection. This is a collaborative team-based process. That's not terribly different than traditional qualitative analysis. What is somewhat different is that in RQA, you have concurrent data collection and analysis, meaning that you may collect data, do some analysis shortly after, and then iteratively go between those two as well. And so through that, you're hoping to slowly build and generate real-time findings. And finally, this is a really action-oriented process. You are hoping to identify recommendations, potentially during the evaluation of a program, the implementation of it. So these would be findings that are going to have direct implications for the next steps for projects. So there are some similarities definitely between traditional and rapid qualitative analysis methods. And if we were to look at them in terms of how they're common, they do have very similar purposes and draw from the same types of data and frameworks with that. However, some of the differences though between them is when we think about traditional methods, the goal might be to more develop, if you're using something like grounded theory, to actually develop a theory of a particular phenomenon, whether it's behavior, an outcome, topic, and through that to really gain in-depth understanding of that by immersing yourself within the data and through that really getting to learn about it inside and out. Rapid qualitative analysis, on the other hand, purpose is it's meant to be actionable, so to create concrete recommendations, and there is that time-bound nature to it. So it's really two different halves. There are different frameworks that come into this when we think more methodologically. So traditional, it may be much more inductive in that you are allowing your themes and your codes to emerge from what you see in the data through open or broad coding. That's not to say that it may not be deductive. You may also have deductive codes within that. But in RQA, it's primarily deductive in that you start out with a framework that you're hoping to fill in the information there. And so it's very much an a priori or beforehand structure that you're developing with that. It may also be heavily aligned with theories or other frameworks. So if you're familiar with implementation research, the Consolidated Framework for Implementation Research has many applicable constructs. There are 5 main domains for it: the inner setting, the outer setting, characteristics of the individual, and the innovation or intervention, and then implementation processes. And so you could potentially start out with these more deductive buckets that you're trying to fill in as you go through it. The actual data that you're looking at typically is the same between the two processes. Anything that's observational, could be text, could be imagery, could be dissertation, or my dissertation was on Instagram posts, so it could be something that's even a combination of the two. It could also be video with that. However, the difference between them really comes to the extent to which you actually use the data and to what your kind of primary data becomes for the analysis. So in traditional methods, you take transcripts, if it's from an audio recorded focus group or interview, they're transcribed, they're cleaned, you develop a code book, they're coded, usually if you want to report on this finding in a journal, you'll have multiple coders who will resolve their differences. Through that process, both the coders and the team become very integrated with the data and really have that kind of like deep understanding of each of the transcripts and variation between them. On the other hand, for rapid analysis, you may be using something more akin to kind of secondary data, that is data that you prepared from the primary data. So these could be things from meeting minutes, notes that you take afterwards. I'll show you some examples of different ways to take notes and to synthesize those. When it comes to the actual timing with these, depending on how many, if you're doing a qualitative study and it's more traditional, depending on how many, say you're using interviews you collect, typically you'll collect most of the interviews and then begin the coding process afterwards so that you can make sure that you develop a code book that reflects the entire data set with that. There are sometimes where you might do this like halfway through to kind of get the process going a little bit, largely thinking about, that there are, even though we think of it maybe as like a timeless, there are potentially like times that you need to keep in mind with that. But in general, the analysis occurs after most of the data have been collected. With RQA, you tend to do this concurrently. So conduct a focus group, take some notes, identify some findings, use those findings to adjust, refine, revise your data collection methods going forward, which could mean adding to your interview guide. It could also mean starting to fill out what your shell table might be of the things that you're hoping to learn from those focus groups. In terms of the findings that you'll get from that, because of the systematic process, the rigor that goes into the traditional methods, these are often aiming for academic journals, manuscripts that are peer reviewed, developing new models or theories. So very much things that are presentation worthy with that. Whereas with RQA, it may be more internal and like more reporting rather than publishing. And so what I mean by that is that you could be generating summaries for within your team to send back to the funding agency, even to feedback with the participants themselves so that they may have the opportunity to review it. You may also be hoping to, as I said, like modify the interview guide or whatever your data collection instruments are to delve into some things that you find through this preliminary analysis you're going through. The length of this can vary. I have studies. I think that qualitative data, it's never really dead. You could have a data set that's 10 years old and something could happen and all of a sudden, like, wow, I want to go back to that and I want to look at that data set. So one of the studies I'm talking about, we collected a whole bunch of data from uh, family medicine obstetricians, OBGYN, MFM fellows and faculty. We collected all of that in 22. Few years later, or next year, I believe, actually, the Dobbs decision came down from the Supreme Court. And even though we'd completed all of our data collection before that, we realized that, man, if we interview these exact same groups of people, we can have this wonderful comparison of the pre versus post Dobbs environment with that. And so I think that there's a lot of ways that you could always go back and do additional analysis with data sets that you've collected and gone through and done a preliminary analysis on. But with something rapid, you want those findings to be fed back very quickly. So it could be something, sending an email to your PI afterwards or writing a report back to your funder. But it's meant to be definitely a more time-bound nature to that. And so, generally no more than a couple months, I would think, if you're trying to really stick within this rapid time frame with that. Then last is thinking about, what are some of the different settings, physical settings, not as much as like research settings that these may be appropriate to. I don't think that they're necessarily mutually exclusive here, but I think that you often will find more rapid methods and things like implementation, where you need to know something in order to do the next step, or evaluations if you're trying to understand like what's working, what's not working, quality improvement methods as well. Again, where you're looking for very quick synthesis and integration of findings with that. So these are some of the main similarities, differences. There are others, of course, but as I said, I think it's not, I provide this, but if you've been doing qualitative work before, you know that there's a large amount of gray area in terms of, time and the kind of these cutoffs for different phases. It's not like with the census where, once the survey's out in the field, you don't want to change a single thing about it. It's going to reduce all your comparability with the data that came before it. Uh, the distinction between, traditional and rapid qualitative methods, usually it is the time, but I think that these often should be seen as things that go together. And by that, some of you may be familiar with this figure. So this is just kind of showing at least how these two different things can work together. They're not necessarily in competition. They're, I think, often more part of a staged approach where you may want to, as you're going through a project, if it's a 5-year project, there may be long-term outcomes, more short-term things that you need to identify and synthesize. And you may need to, achieve everything from aim 1 in order to move on to aim 2. If you're doing interviews to develop a survey, you've got to analyze the interviews quickly enough so that you can develop the survey and then do the survey itself too with that. That's not to say that, once you've gotten everything you need for the survey, you're going to drop the interviews and never touch them again. But, there could be definitely levels of priority in terms of what you need to learn and when that has to come about. So I do think that these can go in conjunction with each other, and they often are represented as this, that rapid analyses may be more of a preliminary step where you can gain a lot of insight and start to get feedback from others about that and, inform what you're going to do down the road, but still planning on doing the more in-depth systematic analysis, something that at that point then you could publish and instead of just sharing internally. So there are some general steps to follow in terms of conducting rapid qualitative analysis. So I'll include references as well, and you can see there's a couple different papers that go through these. But if you were to kind of summarize what are the main steps for qualitative analysis, first is coming up with some kind of structured template at the get-go. And I think that this can often, at the very basic level, align with your study questions or whatever your objectives are with that. So, for example, if you're trying to understand, what are the barriers and facilitators and suggestions for improvement for hand washing at Presbyterian Hospital, I would think that your template should probably have columns for barriers, facilitators, and suggestions for improvement, where you're going to then be going and filling in that information. So really thinking about that right from the get-go. And being pretty rigid in terms of, that doesn't leave a lot of room for, adding additional columns to that beyond what you'd originally had. So then in going through your data, you've got to collect the data. And after you collect it, to go in and within a reasonable amount of time, give some preliminary analysis and synthesis of whatever those data are, so that you can kind of like data dump from your brain after you do an interview. And so this could be, again, the rapid part of it really comes down to the needs of your project. Is it end of day, end of week, end of month, end of quarter? It's got some kind of deadline usually that you need to have for that. Putting all of that information then into a matrix that is a table is a way to start to build together the comparison across multiple interviews or across multiple data collection points with that, again, using those same categories that you would have at the top. So barriers, facilitators, suggestions, and each row then would just become a new interview, and you would fill in the information with that accordingly. Through that structure of a matrix, you can then start to see this is more like a quantitative data set. And once you've got this all kind of pieced together, then you can look both, vertically, or horizontally, which is across each of the interviews, but you can also look vertically at barriers, comparing them of one case to the next, and that way be able to identify these emerging patterns with them. And then hopefully through that, you can produce some, quick findings about what exactly you're seeing. And you can do this iteratively, updating each week, each month on what you're finding with it. And I think that, if you were to boil this down in terms of like, what exactly do you need to, what are the types of questions that are going to guide your analysis and thinking about, is RQA even appropriate for this? I think there's just two questions you should consider asking yourself, which is, what do you need to know? What is the key information, barriers, facilitators, recommendations, whatever it is? And then when do you need to know it by? And having those two things in mind will give you the kind of action-oriented piece and the time-bound nature of it, which are the real hallmarks of RQA. So, of course, those could vary. There could be deadlines. You could have something developed and then it needs to go through team review. But, the idea is at least to kind of to keep those in mind as you're going through a process. So, first study I want to talk about is Promote OB. So, Promote OB, it's an acronym for Primary Care Obstetrics and Maternal Outcomes Training Enhancement. This is a training program within the Department of Family Medicine and Community Health that's expanding the obstetrics track into an advanced track that's able to do surgical and other procedures like C-section, ultrasound. And the background behind this is that family medicine obstetricians, FMOBs, are essential for providing maternity care in underserved communities, and as you may be seeing in the news, in rural communities in particular. However, FMOBs have been declining, and there's a lot of reasons that contribute to that. Part of it is that there's concentration in urban areas. There's differences in terms of motivations for why people may want to practice in regions like rural areas. And, there's also declining specialty care in these areas from OBGYN themselves. So as a result of these kind of confluence and factors, there's a real growing maternity care desert issue in different communities in the US. And to address this, the HRSA, the funding agency for this grant, funded Promote OB through the Department of Family Medicine and Community Health in 2022 to launch the Promote OB track and expand the current residency option with that. And what that means is this is taking a real collaborative approach. So family medicine has worked with OBGYN, and maternal fetal medicine, MFM, and they're really integrating the residencies between the different departments there to provide additional hands-on training for different skills. There's also an educational didactic curriculum that's been developed to go along with this. And so in order to help prepare and provide findings for this, the evaluation goals are at the baseline, we wanted to explore what are the residents' training needs, what are their barriers to practice, and what are the provider perceived patient needs. And so in order to do that, we conducted 7 focus groups at baseline, so in 2022, with former residents who practice OB from family medicine, former FM residents who don't do OB, family medicine faculty, family medicine obstetrics faculty, obstetrics and gynecology faculty and fellows, and then maternal fetal medicine family and fellows. And so hopefully through this kind of like wide group, we're able to ultimately identify all of these different factors that we could potentially address through implementing Promote OB. So to accomplish that, we developed traditional qualitative tools. This is a piece of the focus group discussion guide here. And you can see it's oriented, it's got main questions, it's got probes that go along with some of these that are generally more open-ended questions, and the probes themselves are meant to dive into these things if people mention them, or if people, if the respondents are being very quiet, these are ways to draw out that information with it. But what I really think is important is that as you're going through the data collection process, I can't understate the value of detailed notes. And this could occur in a variety of ways. This was a focus group. This was actually a virtual focus group, and so we had a note taker, someone who wasn't me, who was actually taking their own set of notes. Actually, I think we had 2 note takers for this one. But as I was going through, I'm jotting down myself right along that on the paper copy of the discussion guide, so that there's a bunch of things that I may be able to capture. So if there are questions that are sticking, I flag it. I can reword that in a revision. I can think of potentially what are some probes that I might add to that. Some people would say things that were, really interesting and stuck in my mind. And so different phrases, and especially if multiple people use the same phrases, I started to write those down. And there are other like follow-up details with this. There's a ton of acronyms. So like AFI, amniotic fluid index, was something, as I'm doing this focus group, I'm like jotting down, I'm trying to figure out to understand this. But these notes, in addition to allowing, me to reflect on the actual discussion guide itself, they also allowed me to start to synthesize and process a little bit of the data. So, oh darn it, dramatic effect. So after each focus group, myself, the other two note takers, we stayed on after the call and we went through and we data dumped right then and there. I flipped over my interview guide and I started to just write down everything that came off the top of my mind. We were particularly interested in understanding barriers to FMOB practice and care and unmet training needs. These could be things then that may inform the development of the curriculum that would be going along with the Promote OB track with that. So after each of the focus groups, we made sure to schedule additional time so that we could go through and do some of this processing. And did this after one focus group, after another focus group here as well. After a third focus group, we did a total of 7. I won't bore you with all of those. But the dramatic effect that I want to show with this is that, when you take notes, even right afterwards, helps to cement some of the things that you see in terms of like what you may see as important. But it also can help you to start to see potential trends across those. And so when I look at my notes with these, I think one thing that really jumps out is that you may see this phrase here, quantity versus quality of delivery, really getting this idea of that there's a huge amount of variability in, what FMOBs perceive as to be an appropriate amount of, in this case, most of them were talking about C-section deliveries. So they were like, what is the appropriate number of deliveries that you've got to see as an FM resident in order to be competent in this? And so this came up in just about every single one of the focus groups. And so in discussing this after the fact, and making sure that we have that time, we're able to start to glean these different things. So taking these together, then we then started to develop a list, and we would send out updates to the group after these focus groups. After we did them with family medicine, we'd send this. And so this is an email that the project manager wrote where you can start to see we're kind of grouping things together across. So you can see in the middle, there's this long bulleted list of specific training needs, things that we might want to add to this. And so, we were very methodical in tracking all of this and starting to get this information because there's a lot of reasons we'd want to do that. So we also saw I used that immediate opportunity to correct some of the different things on the interview guide so that it could be, for the next group, I wouldn't have to reword a question the same way with that. And there were a lot of benefits to doing that quick process. First is that we were able to revise the interview guide, go through and make sure that we could add additional questions and probes to it. We were then sharing those findings. That was an internal lit summary, but then we also presented them to funding agency. There are quarterly training calls with other awardees for the same grant mechanism. So we were able to say, this is what we're seeing. We've done focus groups. These are our main findings within them. We're also able to see, through that process that we did start to see the saturation of themes. So the quantity versus quality, was something that came up consistently. And so we didn't really need to dive too much more into that because we saw there was something that was pretty universally accepted as and one of the issues to address. And then, perhaps most importantly, this really allowed us to hit the ground running when it came to our more in-depth process of developing a code book and then systematically analyzing the focus group transcripts, which recently we were able to publish in the Journal of Primary Care and Community Health, providing, the more traditional type of findings that you would with this. So through this combination of approaches, we both were able to achieve the short-term needs, which was finding out what we needed to learn, what are the unmet needs, what are the barriers, provide those to the group, but then also get this out into the broader literature down the road. And as I said, this is an interesting project. The grant is still active with this, and we're going to be doing a follow-up set of focus groups with this. So we'll make sure that we, in the next series of these, undertake a very similar process with that, of, really processing the data. We'll also have the benefit of now being able to compare it with what we saw in 2022. And so that could be another thing that we would want to explore. Second case study I want to discuss is a study looking at peritoneal dialysis in VA clinics across the US. So just to give a little bit of background, home dialysis, which includes both peritoneal dialysis and home hemodialysis, is associated with a greater quality of life and lower costs for patients who have end-stage kidney disease or kidney failure. Despite that, only 13% of people on dialysis in the US are on home dialysis. And among veterans, just 1 in 10, so even lower than in the general population. Now, this is in contrast if you were to look to Europe or even to Canada, there's a lot greater uptake of peritoneal dialysis for largely these reasons, better quality of life and lower cost with that. So in 2019, federal government issued an executive order, which was the Advancing American Kidney Health Initiative, and it aimed to increase home dialysis use from the 13% at baseline to 80% of new patients with kidney failure by 2025 this year. I cannot provide an update on if we have hit the 80% target, but I'm just going to gander that we probably have not with this. Now, the goal of the current study was that we wanted to, within the Veterans Administration, specifically looking at veterans on dialysis, we wanted to understand what are their barriers and facilitators to using home dialysis modalities, and in particular look at peritoneal dialysis. There are other types of home dialysis, home hemodialysis, but peritoneal dialysis is the particular study with this. So the study design that we embarked on, and we completed data collection for this, is that there were 6 in-person site visits to VA dialysis clinics, and these were clinics that had both hemodialysis and peritoneal dialysis. Not every VA clinic has peritoneal dialysis or offers the home options. In that case, they have other alternatives. They may go through community care with that. Now, this project really embraced the rapid qualitative inquiry design, and to that end, there are a variety of different data collection instruments and sources with that. We did in-person observations. We went to the different dialysis clinics. We sat in the waiting room. We went and did a tour of the actual facility itself. We created maps. We shadowed patients during their visits with their nephrologist. We, when possible, sat in on the chronic kidney disease orientation, the training for peritoneal dialysis that people had to go through, or basically any other patient education and training that the nephrology department was offering as it relates to hemodialysis choices. So a very large amount of data was collected with this, and the goal was to hopefully, through this really immersive process, to be able to come away with some really really conclusive findings about what are the big barriers and facilitators to getting veterans on PD. Excuse me. So I'd like to show you some of the data collection instruments. I think this is really what set us up for quick synthesis of our findings. So, as I said, we had both observational data and we had interview data, which was the recordings of interviews, and we had transcripts from those. But before we went to our first site even for this study, which is called Let's Grow Home, we developed several of these instruments that would hopefully facilitate our analysis down the road. So for the observations, we had observation guides that included a mixture of both open and closed-ended items with this. And this, I condensed it a little bit, but there's definitely, you could have space for this to provide as much text as you wanted with them. And the goal with this is, again, to, get us as the people who are seeing this, to really process what we're seeing around us in any way and get us to start writing these different characteristics down. So, it could be anything as small as like, did it smell like bleach in here, to, noticing if people are talking to each other. And for most of the site visits, we were there, we were there for at least 2 days in all of them. Some of them we were there nearly a week. So by the end of it, kind of it blurred the lines between observer and participant. And in some cases, a lot of the clinic staff and the patients themselves really had gotten used to our presence, which may have potentially something we'd want to acknowledge in the limitations of the study. But we had these great data collection instruments going into it. So this was a clinic observation for the shadowing guide, or this was one of the clinic observations. This was for a shadowing guide when we would go in and visits with patients, and also typically their caregivers, and meet with their nephrologist, as well as the PD nurse, the peritoneal dialysis nurse. And the shadowing observations, again, very similar combination of both open and closed-ended items here that we could fill in with that, and go in and allow space for expanding as necessary. Now, these were all from the actual like observations themselves, but I think what really set this study apart in terms of like moving it towards rapid qualitative inquiry was we had this great debriefing process. So at the end of the day, each individual on the team would take, I forget, like 10 minutes, 15 minutes, depends how much time. Usually this was after the lights were going off at the VAs. So we're the only ones in these conference rooms doing these debriefs, but go through and do them. We did an individual debrief, largely open-ended questions, but also still having some of those closed-ended items there at the top. Went through that process. And then afterwards, what we did is as a group, synthesized our findings across everyone. And similarly in terms of like formatted, like the open-ended, closed-ended questions. But this is something where at the end of each day, what we would do is we would update this document. And in the first site, what we learned was that we're like, hey, this is actually a fantastic tool. So we go through first day, update it. Second day, go through what did we see, add to it. And so we would do this very iteratively at each of the sites. And so by the end of each of the 6 site visits, the group debrief guide, in some cases, was like 10 pages long. And it was so full of information, and the information was gleaned from different sources, from the observations we'd been doing to the shadowing. We also were conducting interviews. And so, if I sat in that day on an interview with a caregiver and their veteran, and I heard something, that could be something that finds its way to the group debrief guide here, independent of like transcribing the recording and then coding it and extracting it there. So the group debrief guide allowed to this, real nice synthesis across team members to pool together this information into a meaningful format. And just to show you an example of what one of these looks like, this de-identified cleaned here, you know, we did go through and were able to fill in these different domains. And so, for instance, there's this framework we're looking at called the patient journey, and different stages of the patient journey include education, training, initiation of dialysis, maintenance of dialysis. And so we really wanted to be able to say, like, have we been exposed to all stages of the patient journey? And so through our debrief, we were able to see, okay, yeah, we did hit that goal. Every single one of the stages we account, or at least we saw what we wanted to. We also could see that we were able to speak with any different type of participant that would be there, be they VA staff or clinicians, the veterans or caregivers. And then with each of the sections of the debrief document, we provided updates to it. So we tracked reactions, starting to identify different challenges, barriers, and facilitators. And this is something that by the end of this site visit, this one you could see it's January 8th to January 12th. So this was a 5-day site visit. We collected a lot of data. And this is just the single document. In addition to this, we also have everyone's individual shadowing, and we have interviews with them. So it's a real like large amount of data coming out of this, well over 100 interviews. And given that this is a talk about rapid qualitative inquiry or analysis here, it was super important that we take these debriefs and we take what we learn from them, feed them back to the site as quickly as possible, which we were able to do. And we had a nice template to start. And so what we found is that after each site visit, we would put together a site visit summary. We would provide some general background information about the study, and then we would highlight what we saw as the main recommendations for increasing peritoneal dialysis use. And then broke down as well to provide like the methods, like what did we find, what did we do, and to give them a little bit more flavor for that. And we really tried to present things in groups of 3 so as not to overwhelm them. So what are the top 3 barriers? What are the top 3 facilitators, top 3 recommendations? And yeah, these were preliminary. So we would, after the site visit, oftentimes even on the, airplane ride home, Dr. Reddy, the PI for this study, may have been working on it and starting to put it together. But this is meant to be something that we shared with the sites so that they could themselves, if they wanted to expand it, could take to their, that specific VA's leadership to be advocating, this is what we may need to do if we want to expand PD here. We need to get more staffing, or we need to, you know, have a larger catchment area. So a variety of different factors were identified. And as we've gone forward with the analysis for this, we've been able to synthesize these findings across all of the different sites. And this has set us up really nicely to try and present some of these findings in the traditional academic formats, like a manuscript. So we found that there was a real lot of facilitators to PD, the biggest being that engaged staff really cultivate positive relationships with patients and their caregivers. And there's, in a lot of cases, round the clock assistance from these super dedicated PD nurses who oftentimes are the only person in their position. And so it's kind of like a weakest link where if a PD nurse disappears, goes on vacation, that clinic actually has a lot of trouble filling that role there and providing support for PD patients. So it's definitely calls to a facilitator being the dedication from them. But a flip side to that coin is that staffing was a huge barrier. If you've only got one person in that role, when they go away, you can't really function, or the PD clinic can't continue to function as well as it could with that. And other factors as well associated with that. We did 6 in-person site visits, and as may not be surprising, interpersonal dynamics play a large role in how people operate in the workplace, particularly in a setting that's, most PD clinics were pretty small and less than 20 patients, I think, at max. And so, there are these interpersonal frictions as well. Now, we wanted to balance exactly how we presented that, and we didn't really highlight those things in our reports back to the VAs, but they are definitely things we may address when it comes to the paper itself. And thinking about what are the analyses we are continuing to work on. So the couple different things that we've done is we're putting together a manuscript that's looking at the barriers and facilitators at large with them. But we also wanted to map out, what exactly does PD look like at these different sites? Because if you've seen one VA, saying is that you've seen one VA. And that is actually absolutely the case here. And so when we look at actually putting together our academic manuscript for this, what the research coordinators are doing is going through and we've got each of these different steps. And for each of the sites, then they're going and filling in what they see as the response to these different steps. So at site 1, what is the process like for referral and identification? At site 2, what is it? And they're doing this, and in the more in-depth analysis stage, they're able to attach quotes with it. They're able to say, like, this is a quote from a participant. So you're actually having the primary data to back up the kind of summary statement that may be more typical in the rapid stage. And through that, you can then facilitate this comparison. So one of the great things is that in analyzing each site's, in looking at each of these factors by each site, you can again do that kind of vertical, horizontal analysis where you're looking at referral and identification across all of the sites. And in doing that, you're able then really, I think, to see what are the similarities and differences across these. Now, this may be something that could be done in the rapid approach. We did not develop this at the beginning. So if this is something we'd had going into the site visits, we may have, had some of that work. But, this is to say that you can still use some of those same processes and, thinking of what are my results going to look like? What would I expect them to look like? Not exactly like what are the results themselves, but like what is the table shell going to be with this? How do I want to present my findings in a meaningful way? You'll want to have primary data quotes, but you'll also want to have the summary data as well about that. And this project, we're continuing to work on it. We've got at least one paper under revision and another in development with that. And where am I? Oh, third final case I want to talk about is working with a collaboration between Penn Medicine, or specifically the Center for AIDS Research, CFAR, and PDPH, the Philadelphia Department of Public Health. And what this project is building off of is this protocol called the Expanded Interventional Surveillance, or EXIS survey. And the EXIS survey is something that's part of this overall program called Cluster Detection and Response. But the primary objective is to use the EXIS survey to review responses and to respond to HIV networks that are experiencing rapid transmission by identifying actionable strategies for both the treatment of HIV and the prevention of HIV for people who are HIV network members partners. That is, if you have an HIV positive person, they're HIV negative partner with that. And so this is a project that is building off of a surveillance system that's already in existence at PDPH and at most departments of public health, where they are able to identify, who is in this, which different HIV clusters, molecular clusters, and other clusters are increasing rapidly. And to that end, we've been working with them to develop a mixed methods evaluation where we can try and understand particularly how we can leverage the EXIS survey findings with community insight and ultimately develop strategies that are, again, going to be addressing HIV prevention and treatment within those networks. So through a structured approach, we've gone through multiple rounds of this, and I'd like to point out the process to you. So EXIS is the survey where the Department of Public Health meets with individuals who are in the network. It's a series of questions asking about medical history, background, attitudes, treatment, risk behaviors, a variety of different things. The EXIS survey then gets boiled down into a case summary by one of the PDPH researchers. And what happens then is that we have taken, starting in June, on a monthly basis, we've taken a sample of individuals from clusters and presented the EXIS findings to a case review team, which is a group of people largely from within PDPH, also involved with HIV surveillance and treatment, and present the findings to them and ask them to basically ask any questions. Is there anything you want to know? We describe a variety of different things, responses from the EXIS interview. And then the case review team goes and completes a survey themselves, a Qualitative survey, and we ask them to, based on the case summary that they have, to identify the top barriers and facilitators for HIV prevention or care with that individual. We also ask them to provide a single recommendation about what the next course of action should be for that individual. We ask them to provide this after each case. So we have case level information, and in a given meeting, if we go through 2 cases, they'll provide responses for those. And what's happened afterwards is then we've taken those findings and synthesized them to identify the top barriers and facilitators and recommendations, which are then presented to an external group, which is the Community Action Team, which is not just within PDPH, involves people from across the city that are involved in this work. The Community Action Team has been reviewing what the case review team identifies as their main barriers and facilitators. And through that work, what they've done is go through and try and identify what are some concrete strategies that we could be implementing to try and address this and ultimately to try and respond to these rapid transmission rates. Through that work, what's come out of it is one of the first steps is this PrEP work group. We've taken people across the city who are involved with PrEP uptake, whether they're case managers or clinicians working in the different health systems or in FQHCs as well. And really, we've taken this and tried to implement then a strategy to increase PrEP uptake. Because what we learned from EXIS interviews, from the case review team meeting, the community action team, was that there's a huge missed opportunity for increasing PrEP, and that a lot of the barriers that we'd seen for people were things that could potentially be overcome towards that. And so this is one of many potential strategies that this project is taking to going and trying to put into action. So the first case review team meeting was in June. First community action team meeting was in July. First PrEP work group was in August. And this is something then that is very much working to implement a very quick strategy here. And as I'll get to in the next couple of slides, I'll show you some of the different things that we've identified through this process. So EXIS itself, ton of different domains, a lot of questions. And this is something that's done in person. So it's an orally administered survey. And we're actually going to be starting to record it now because one of the findings we've seen is that we want a little bit more room for open-ended responses. And we also would love to get it in the participants' own words for some of this when possible. So the EXIS survey, though, has a variety of different domains, and the PDPH coordinator goes through and creates a case summary based on the individual's responses to those. We present those to the case review team, and then they fill out a Qualtrics survey where they identify what they see as the top barriers there, and they can check as many as apply. And you can see these are relatively neutral categories here, and we do also have the option for people to expand and provide free text for these. But the first stage, though, is that they go through and they select what they are, and then they have the option to rank them of the ones that they selected, which is the top, or well, which are the top three, the top 1, 2, and 3 with them. And again, also leaving room for free response if someone thinks there's a barrier that's not represented in the list, they can add that in there as well. We then ask them to provide the facilitators. And this we give them a little bit more space to write in there as well. And this is something where, as we've been identifying facilitators, we may add at the future CRT meetings kind of a similar thing where it's like our pre-populated list of facilitators. But since we're in the generation stage with this, we're leaving it open-ended. And then the last is that we ask them, what is their single course of action for this individual? So this process, even though it's staged and we're in the process of implementing it, has yielded quite a lot of valuable information. So we get through each one of those meetings great case level factors. For individual cases, we get 14 people providing responses. If that's how many on the meeting, I think it's typically about 14. And we're able to rank and prioritize exactly what the main barriers and facilitators are and what the potential recommendations for care are for that individual. We also then, since we are doing this multiple cases within each meeting, we are able to aggregate this and also identify not just the individual case level factors, but when you look at the clusters themselves, what are the factors that you see across multiple individuals? And it's through some of these more aggregate analysis that we really started to see PrEP come up quite a bit and seeing at least as potential opportunity for that. Now, the way that we have processed this data in terms of integrating it across these is that we use a structured matrix, which is just a spreadsheet where we've got the rows are each of the individual cases with which cluster they're from, some basic characteristics about them, and then what we found through those case review meetings. And in coming through this, as I said, we're in the beginning stages of trying to implement a strategy specifically about PrEP itself. But in coming together to actually focus on how are we going to try and address PrEP? For the first PrEP work group meeting, we took all of the findings from the survey beforehand and we pulled out basically anything related to PrEP or HIV prevention. And we were able to say, okay, PrEP work group, we've been collecting EXIS surveys from individuals in these clusters. We've had researchers and surveillance individuals at PDPH go through and synthesize what the barriers and facilitators recommendations are. And in presenting these then to the PrEP work group, basically it's like, this is your buffet of options that we have identified through this community engaged process for how you might move forward. And through that, we're going on a couple different levels right now. We're focusing on provider-focused education and training, as well as implementing a community health ambassador program, CHAP, that's going to be working on more of a peer-to-peer level with this and trying to get people to take tests and then really try and cement the same-day linkage. So, talk a little bit about total data dump. That was total data dump, throwing a whole bunch of stuff at y'all. But give a little bit of a recap with it in terms of, what are your next steps if you want to be embarking on this. As I said, there's a very defined approach to going through and trying to understand, what are the different steps if you want to do RQA versus traditional analysis. But I think that, before you even dive into the steps themselves, just ask yourself, what do you need to know? What's the most important information I need to know from this? And when do I need to know it by? Because depending on, again, is it for an abstract? Is it for a proposal? Is it for the next meeting? Whatever it is, just to be having those things defined and to think about this at the get-go, maybe which pieces of this project do we want to kind of like carve out and have quick feedback on, which ones of them maybe might take a little bit longer with that. Because I think ultimately, as I said, these aren't really mutually exclusive. They should work in conjunction with each other. They can build off of each other in, rapid qualitative analysis could provide some, early findings about things that could then be tailored as you go through and actually develop a code book and systematically analyze the larger data set, the actual primary data itself. And there are a couple considerations again. When you want to use rapid qualitative analysis, think about what exactly the aims are of the project. It's got to be done quickly. You've already got some kind of idea about what you're trying to fill in. So it's predefined and pre-structured, and you've got this, feedback mechanism of some sort. If it's not to external stakeholders, it could be even a feedback to yourself, like with the interview guide. I want to be able to tell myself, like, what are the things I should modify in this next one? So it doesn't always have to be just for other people. You can use it for your own purposes if you're the one doing the data collection. And then there's more traditional methods. If you do want to go through that process, you want to do grounded theory, you want to create a theory about this given phenomenon. You've got plenty of time to go through it, and there's resources to do this. You can afford an in vivo license. You are able to transcribe your recordings. There's if you have all of that, then that definitely would be facilitators for doing a more in-depth analysis. And in addition to that, you may also be interested then in looking for those inductive findings, things that aren't necessarily based on your research question. What's the stuff that's interesting and relevant to what you're looking at, and unexpected with that. So I'll close. There are just some potential limitations when we're working with rapid qualitative analysis. So in terms of the uh, different types of data that you've got, I think it really is going to work better if you've got something that's relatively structured. So you've got like an interview transcript or an interview guide, you can follow that, as opposed to like field notes where it's just fully unstructured with that. I think that you do want to have some sort of format with that. I would say also that if you are um, familiar, with the actual like content material, or if you're familiar with the content and the material in advance, then you'll be even better positioned for creating those structured templates beforehand and those shells that you might need with that. And I think that could come, either from previous work or if you're doing some kind of literature review to try and glean what those are. But if you can get someone on the team, though, who's got that kind of like insider perspective, even if it's not you, then they could help you think out, oh, well, like, you may want to in advance be keeping these things on your mind to have that as a potential like category or factor that you're going to be, ultimately paying attention to. Um, with this, the primary data is in most qualitative research, primary data is interview transcripts, photos, quotes heavily on that. In Rapid, it's more secondary data because it's your notes about the data that you looked at. So you really aren't going to be including as much with those. Maybe there's like if you've got like one that came to mind with it, but since it's meant to be something that's summarization, it's synthesis, you really aren't going to be presenting as much that like primary data, unless it's like a super impactful quote, maybe like for a report, for instance, with that. I would say that like, if you are the one who's going on this and pulling this stuff, that, a good quote is very subjective. Everyone will think a different quote is a good quote or a bad quote with it. So I think that, knowing at least that this is going to be summary information would help you just to avoid that pitfall. And I think this is collaborative, team-based. Everyone's going to fill in those matrices differently and use different language with them. So this is good why it's important for multiple people to be weighing in on something. With the focus groups for Promote OB, I had my notes, but then, Caroline had her notes and Melissa had her notes, and we all took our notes and triangulated those. But if it was an interview and it's just one person doing it, that does introduce some potential bias with it. And so, so in that case, that's just something to be aware of. It's one of the limitations with this, because if you were to write a paper about it, they'd be like, oh, only one person analyzed this? No, you got to have two at least, multiple eyes on that. Then I think, beyond that is that there are a lot of barriers to publishing these findings, specifically because of these different reasons, that you're not going to have a lot of primary data. It could be limited in terms of who's looking at it, who's doing the analysis. It could be one person, who's actually like doing the interviews and the things afterwards with that. But there's definitely some limitations if you want to publish on this, that, if you're going to go in a qualitative journal and report something on interviews, but not having done iterator reliability or codebook development, I would expect that they're going to have some strong feedback about that and suggesting that you go back and do a more in-depth process with it. So it's a couple minutes after I intended with that, but thank you all very much, though, and really appreciate your time.
Thank you so much.